Me well. Uh, Nyasha, I know you have a lot to present as well, so I'll try to not to take too long. And I'll put a timer right now. So thanks very much for this opportunity to present on one of the study of the TB Speed project. As you should know, this is a teamwork, so I'm presenting on behalf of the TB Speed Health Economic Study Group, which includes some of the people in this group, including Martin Hacker, Nyasha, and Pete. So, although many of you, will be familiar, TB in children, the burden of childhood TB is still high, with approximately 1.2 million new cases and 210,000 deaths in 2021. It is estimated that 96% of these deaths are those not treated, and only 40% of these new cases are diagnosed. And this is explained by the fact that TB is particularly difficult to diagnose in children, because they would have either fewer symptoms or would also present asymptomatic. They will also have lower bacterial load, which means challenges in confirming a diagnosis. They are also challenging for obtaining samples, and diagnosis usually is typically made by a specialist, and particularly at the tertiary healthcare level. As you know, the diagnosis can be either bacteriological with microbiological confirmation or based on the clinical decision. And since 2022, WHO recommends decentralizing childhood TB services. However, there's limited evidence on how and where decentralization should occur, and no economic evidence. So TB Speed, a bit of background. So one of the studies specifically look at the impact of a decentralization strategy before, using a before and after design. There were two levels that were explored. Patient level to improve the overall diagnosis strategy with a package that included systematic screening, clinical evaluation, microbiological diagnosis using novel sampling approach at the time at least, such as stool and nasopharyngeal aspirates, as well as the optimized chest X-ray reading. So that was for the patient level design of the intervention, and this was decentralized to secondary healthcare level at district hospital level with a DH-focused strategy where screening, testing, clinical evaluation, and chest X-ray would be conducted at district hospital with some referral and screening activities at PHC level, or a fully decentralized approach, primary healthcare focus strategy, where screening, testing, clinical evaluation would be conducted at secondary and primary healthcare level, with some referral activities for chest X-ray reading for severe cases. So the Health Economics Research Group, was interested to assess the cost effectiveness, and budget impact of this intervention, with the strategy, either DH focus and PHC focus, compared to standard of care across countries. The study was in 6 high TB incidence countries, including Cambodia, Cameroon, Côte d'Ivoire, Mozambique, Sierra Leone, and Uganda, and was conducted between August 2018 and September 2021. In terms of methods regarding costing, so we conducted primary data collection, ingredient-based costing in all 6 countries. That included time and motion study, which aimed to estimate a proportion of the time of healthcare workers allocated to these new activities, so that we can also estimate personal costs. We estimated activity-based cost parameters feeding into the cost effectiveness model. We conducted an incremental cost analysis to the standard of care, and only costed extra resources needed for this intervention, and that included training, personnel, equipment, some supplies, and delivery chain costs, as well as maintenance costs for equipment. And so we excluded health facility operating costs, or both service level costs, and research-specific costs. The model for the cost effectiveness model used a decision tree structure based on patient care pathways. It relied on a R package 8.3 developed by Pete. Economic analysis were based on the modeling and included trial and literature data. We adopted a healthcare system perspective, and working with clinicians, we were defining the patient care pathways standardized across the 6 countries. And so this is a very basic overview of the model, but what was important was that we're accounting in terms of inputs to clinical effectiveness outcomes coming from the clinical study, and that included the number of patients screened, possible presumptive TB cases, patient tested, and patient treated for TB. We also used the cost of resources, as I just mentioned. We also accounted for some of the child characteristics, such as age, HIV status, and antiretroviral treatment status, and accounting for other related data that would either, in fact, direct either effectiveness or costs. That included sensitivity and specificity of the diagnosis tools, other data such as lost follow-up, referral rates from PHC to DH, as well as TB prevalence, for example, which was kept constant across countries. Model output included some health impact, health outcomes, such as children treated for TB for each arm per 100,000 patient presenting, death averted, disability adjusted life years averted. Maybe I shouldn't say as well in the DALYs, we disregarded the contribution of morbidity to the estimation of DALYs. There is a bit of debate on this. Health economic outcome included cost per 100,000 patient presenting, as well as incremental cost effectiveness ratios expressing cost per DALY averted. For the budget impact analysis, we calculated the annual cost of nationwide implementation for each country over a hypothetical 5-year implementation period. We used the base case of 3 years to install equipment and 5 years to have all staff trained and a full rollout nationally. One-off implementation costs. So costs, for scale-up were differentiated between one-off implementation costs and ongoing routine costs. One-off implementation costs included equipment, as well as the equipment delivery, installation, and maintenance, as well as staff training. And routine costs were included drug costs, supplies, as well as personal costs, and were, as inputs for the budget impact analysis, used as input-specific outputs of the cost-effectiveness model. In terms of model impact, we simply used incremental projected annual rate of tuberculosis notification in children based on the data from the TB speed study, and also using WHO Global TB Program database. Additional input that were used for the budget impact analysis, for example, included the number of national numbers of hospitals, clinics, as well as healthcare workers, and annual rate of TB notification in children. So in terms of projecting cost at scale, we used a fairly simple approach to an accounting cost function, differentiating cost by type of inputs, also differentiating by healthcare system level we were interested in, and by country and by year of implementation. In terms of results, so the model cascade of care showed that screening rate increased from 20% in the standard of care to almost 90% in the intervention arms, and obviously this was expected since we were promoting a systematic TB screening. The rate of children identified with presumptive TB among the screened children remained constant across the arms. The rate of children initiated on treatment among those identified with presumptive TB increased from 12% to 18% in the DH-focused strategy and to 14% in the PHC-focused strategy. And we didn't find significant difference between age group. So in terms of results, as expected, obviously the comprehensive diagnosis approach, the TB speed intervention, was much more expensive than the standard of care. Although we also found that we also found higher effectiveness in terms of number of TB diagnoses, as well as fewer deaths. And one should note that the PHC-focused strategy was not only more expensive than the DH-focused strategy, but also a little less effective. Just a bit more nuances in terms of how we were looking at the cost per child treated. in terms of by category of cost inputs and by TB care stages, what we could observe is that supplies, were one of the main cost contributors to this health economics measure, and mostly driven by the cartridge kit used for microbiological testing. And equipment also was one of the main contributors to cost. And so when looking at cost per child treated by TB care stages, you could see that most of these contributions were coming at the testing phase stage. In terms of results on the cost effectiveness model, the acceptability curves showed that incremental cost effectiveness ratio for the DH focus strategy were ranging between 263 for Cambodia versus up to 342 for Côte d'Ivoire. For the PHC focus strategy versus stock, they were ranging higher, 477 for Cambodia and up to almost 600 in Côte d'Ivoire. So what this shows is that the PHC focus strategy was dominated, again being more expensive and less effective than the DH focus strategy, and differences that were observed between countries were due to prices and cost inputs then, and different life expectancies in the countries we were studying. If we are interested to look, to look at this health economic outcome, compared with cost effectiveness thresholds, which are obviously subject of debate. So I mean, we had to, we in order to provide some context and to inform decision making, we included and compared our results with these thresholds. We used the OCHALEC 2018 thresholds. What we were able to see, as you can see here, is that the likelihood of cost effectiveness was mostly, most likely for Cambodia and Côte d'Ivoire, and still fairly unlikely for the other countries, and unlikely to be cost effective for the PHC focus strategy versus SOC in any country. But these results were very sensitive to the TB prevalence in the model that was set up, with increased tuberculosis prevalence leading to much lower actually incremental cost effectiveness ratios. And that was a similar result that was observed for the PHC focus strategy. And we also found that discount rate applied to live year saved also had impact, and lower discount rate applied, leading to lower incremental cost effectiveness ratios. In terms of the budget impact analysis, as a complementary piece of information on this economic evaluation, as you would expect, the cost of setting up these new strategies were substantial and ranging between 7% to 54% of the current annual TB budget in each country for this 5-year hypothetical period for the DH focus strategy, and between 18% to 163% for the PHC focus strategy. However, most of these costs would be incurred in the first years, because they were mostly linked to the purchase of equipment that would be needed for these health facilities. And so once these expenses would be made, ongoing annual running costs would significantly decrease from 3% to 44% of the annual TB budget for the DH focus strategy, and from 1% to 17% of the budget for the PHC focus strategy. As you could see, there were important differences observed between countries, and these were due to the size of the population, the TB notification rates, as well as the number of facilities to equip. And for example, Mozambique had a very high rate of TB notifications, or a very high expected number of TB cases to be found, whereas Uganda had over 5,000 PHCs. And so obviously, when looking at this data, when looking at these results and interpreting and contextualizing them, a lot of things need to be considered, and among them are, for example, the synergies that exist on using these new equipments to other disease or to other patient groups, such as adults populations. And then another piece of information on the budget impact is that For example, taking the example of Cambodia, we could see that the cost drivers at scale were, again, but with a lot of variation between countries, but we're highly dependent from the set price for these cartridge kits, which are per unit are $10 for each patient, and basically any other factors that would affect the overall equipment costs. So obviously within the context of TB speed, we only had a sample of sites that we were observing on which we had access in terms of data. So for example, we had some uncertainty in terms of the actual percentage of digital hospital already equipped with some of this gene expert and chest X-ray machines. Maintenance costs, for which we accounted for as 15% of purchase price, is often ignored, but can potentially be a significant cost, in particular if we are, discussing the context for the intervention at secondary or primary healthcare level. And we also work with Doctors Without Borders Logistics, who provided us with additional nuances on equipment costs because they were conducting some market screening activities for us, more specifically on the mucus aspirator costs, and also provided us with some estimates of potential economies of scale and specifically on international equipment delivery chain costs. So to conclude briefly, so the TB speed decentralization study did increase to a certain extent diagnosis and reduce death. However, cost effectiveness of the intervention did vary a lot between countries, was highly dependent on TB prevalence, and obviously the threshold that you would define in each country. And the budget impact and the budget impact analysis also provided additional information in terms of the financial feasibility of implementing full scale of such an intervention. However, further work or further nuances or further contextualization needs to be done when using this data for national planning, in particular relating to the these potential efficiencies on equipment for patients, for other patients and other disease. Exploring alternative for cheaper equipment and negotiated price for some supplies such as the cartridge. And from an implementation perspective, potentially also concentrating on higher TB prevalence areas at provincial or district level. So I think that's it from my side. So I would like to acknowledge all the partners on the project and also to thank you for your attention.
Thank you very much. Does anyone maybe have any clarification questions or anything before we go on to Nyasha? And we can have discussion at the end. Tess.
Yes, I have a quick question. Thanks so much, Mark. That was a great talk. I was just wondering if you could talk a little bit more about what is driving the fact that you found the PHC decentralized strategy to be less effective than the hospital strategy, and to what extent that result is sensitive to your assumptions about the loss to follow-up rate during that referral step. Thanks.
Yeah, thank you, Tess. That's a great question. It's not necessarily easy to answer. I think the first answer, short answer, is that the results for the PHC focused strategy were a bit surprising, to say the least, in the sense that they didn't diagnose very much. And so, we're also working with a team of social scientists who have been conducting some work on the acceptability of such an intervention at primary healthcare level. And so what they found, for example, is that, there was, potentially a lack of confidence in establishing a diagnosis at primary healthcare level, without, because it does take a bit of confidence. So I think, for putting these children for quite a few months on treatment. So we know that these contextual factors or behavioral factors were definitely one of the driver. regarding our assumption on the loss to follow-up and how this potentially affected, I'm trying to think out loud how this would have impacted. I cannot remember at the top of my head how this have affected our DH focused arm. Sorry.
Okay, thank you.
I mean, I think the short answer on loss to follow-up is that wouldn't make a huge difference because the key issue was in the clinical trial, it was just less effective. So we got fewer diagnoses out of it. So, I mean, if there'd been perfect transmission of everyone who was asked to go to hospital, who went to hospital, possibly that would have made a small difference. But I think there weren't actually enough people being referred to hospital who should have been anyway. So it wasn't, in theory, those not diagnosed locally would ideally have been referred to district hospital for further investigation, but that wasn't kind of universal.
Okay, I guess I was thinking loss to follow-up in the district hospital form of the intervention, but yeah, we can talk more after if there's time. That's helpful. Thank you.
Yep.
Brilliant, thank you. I have a couple of questions, but I'll save them for the end maybe so we can have enough time for Nyasha, unless anyone else wants to ask anything now. All right, Nyasha, over to you.
Sure, thanks, Finn. Just trying to find the. Oops. I hope you can all see my slides.
Yep, we can see that. Thank you.
All right. Thanks. Thanks a lot, Finn. Yeah. So, and thanks, Mark, for great introduction. That saves me a lot of minutes. Okay. So yeah, I was going to go through a brief background and hopefully go through two studies. It was quite ambitious on my side, but I hope I'll be able to do that in time and provide a summary of both these studies. So not repeating what Mark has already said and what you already know in terms of the burden of TB in children. The only thing that I wanted to highlight on this slide was that out of the total deaths in children, 95% of those occur in children who are actually not treated for TB. So finding them and treating them will actually make a huge impact. These are just some documents that we're all familiar with, recent recommendations or recommendations from WHO on decentralized and family-centered models of care, as well as provision of prevention treatment for people who are actually at risk of developing TB disease. While these recommendations are available, there's actually very little evidence on cost effectiveness of either these models of care for TB in children. So our work is actually trying to provide some evidence in that regard. So the first study that I'm going to talk about is called TP, which stands for TB Innovation Project, which was a pre and post implementation assessment. This was implemented by Elizabeth Blazer Paediatric Foundation and funded by Unity Aid. More details about this work is actually available in a publication in PLOS-Med. So the aim of this assessment was to evaluate the cost effectiveness of multi-country CAP-TB interventions that focused on two main things. So scaling up facility-based intensive case finding and anti-tuberculosis treatment, as well as strengthening household contact management and TBT provision in HIV clinics. I'll just give a brief overview of the CAP-TB project. which I'm sure most of you are familiar with. And if you want more details, you can actually find them from our ECBAF website. So the goal of the project was to reduce morbidity and mortality due to pediatric TB. This was a 4-year project. And it was implemented across 9 sub-Saharan African countries, as well as India. These are shown on the beautiful map on the right, which actually also provides further information on these countries, for example, TB, HIV, as well as the role of public or private funding. So India, in particular, focused on pediatric TB finding, which included the private sector, and is not included in the current analysis. And of course, the target population was children under 15 years. As I have already mentioned, the interventions that the CAP-TB project focused on was facility-based ICF, as well as trying to improve TB preventive therapy. So just a bit more details about these interventions. So the TPT interventions were focused on 2 entry points, 1 HIV clinics, as well as the household entry points. So in terms of what they actually did, so under the HIV entry point, they held healthcare worker training on TPT. They also had regular monitoring of activities during on-site support and supervision. And the preferred regimen for children with HIV was 6 months of isoniazid. Then under the household entry point, so they had community-based contact investigation and TB screening where possible, so it's for all index TB cases. And they referred children to relevant pathways depending on whether they were symptomatic or asymptomatic. So asymptomatic children were referred to facilities for final assessment and TPT initiation if they were eligible. And then symptomatic children were referred for further TB investigations. They also introduced things like contact investigation and TPT registered in facilities where these were not available to try and actually capture this information. Then they also had some training materials, information to provide more information on TPT for caregivers. The main regimen used was 3RIH in selected countries. These countries who were willing to actually adopt it as the new regimen. Otherwise, they were just using the regimens used in their standard of care. In terms of the intensified case finding activities, so these were mainly focused on district hospital level, as well as the lower level facilities. And the main aim was to actually try and incorporate systematic TB screening at different child health entry points with OPD, IPD, nutrition, MCH, and HIV as examples of those. And they used a pediatric TB adopted symptomatic base 2 to actually screen children for these symptoms. They also had community health workers helping out with screening of children. And they also had on-site pediatric TB training to try and improve the capacity for healthcare workers to screen and diagnose for tuberculosis. In terms of the methods that we use for the modeling, we first quantified the impact of the intervention on ATT and TPT based on before and after rates of initiation obtained from the TP study. We used a Bayesian model to estimate country level rate ratios. We also estimated unit costs of the intervention components by analyzing project expenditure data and also the cascade data that was provided by the project. Then we used mathematical modeling to combine these and project health impact, system costs, and as well as cost effectiveness. So this is just a modeling logic of what we actually did. So I've already mentioned the goal was to project changes in health and health and as well as costs. So on the left furthest of the diagram, we have how we estimated the rate ratios for change in ATT in relation in ATT as well as TPT by comparing the before and after accounts data observed from the study. Then we attached relevant heads upstream. So this is shown on the diagram B, where for each of ATT or PT, we attach cascade upstream to enable estimation of costs based on the level of effort required to actually start someone on ATT or on PT. Then downstream of those two quantities, we projected mortality and life years using a case fatality rate based framework. And we estimated disability adjusted life years as the model outcome. And we incorporated a PSA-based approach in all our modeling to capture uncertainty associated with different parameters. This is just a brief overview of the costing. So the aim was to identify and also value resources used. We estimated unit costs of activities in standard of care based on literature. And as I've already mentioned, unit costs under the interventions were estimated using project financial records, where we disaggregated costs by cost type and then activity, and we divided the estimated costs by the number of units for each activity. For example, the number of children screened or number of children tested or investigated for TB. Then the unit cost of activities under the intervention is just to sort of highlight that they actually include investments made to implement the intervention. So these are the investments made to try and improve on activities that were available under the standard of care. The right side of the slide just shows some of the activities that we estimated unit costs for. So going into the results, this is just showing the estimated intervention effects. The busy plot is showing a comparison of like the M sort of unfilled circles represent site empirical rate ratios. Then the X is the country level summary sort of estimate, and then you have the black dots with the intervals representing the Bayesian meta-analytic estimates. And as you can see from, so the first panel on the left is anti-tuberculosis treatment, and the panel on the right is TB preventive therapy. And this is described first by 0 to 14 years and then disaggregated by lower age and higher age. And there's general sort of increase in ATT initiation, but it's actually larger for younger ages compared to older age groups. And TPT, while it's actually generally increasing more than ATT. So in terms of cost effectiveness, this is a very busy slide, and I apologize for that. It's showing the level of effort, resource use, and costs, both under the standard of care and intervention. The general point is in comparison to the standard of care, the intervention increased the effort, like in terms of the numbers of children screened or the number of children tested for every child put on TB treatment. With these increases in level of effort, there was also an increase in resource use and associated costs. So just to summarize some of the results, so the median ISA that we estimated was about $640 per daily affected for the combined package. So that's combining ICF and TPT, which is represented on this plot in plot C here. But there was quite a wide variation from a low of 135 to about 6,800, which was, I think, was in Cameroon or Zimbabwe. I can't remember for sure. And more countries were likely to be cost effective at a nominal sort of threshold of 500 USD per dollar rated. That's for the TPT component compared to the ATT forecast component. And as you can see, the combined package at the lower right corner of the slide actually pulled up some countries which actually improved cost effectiveness. However, as I've already said, there was a huge variation. And the main driver of that variation was actually in intervention performance, which we also saw when I showed the intervention effects. And the huge variation could be attributed to different things. For example, the economic situation in a country, operational issues associated with the NTB, as well as influence of COVID, because different countries responded differently. And they had resulting different impacts. And of course, the main limitation of this analysis is the pre-post comparison as a measure of effect, which is vulnerable to trends and shocks, and lacks true causal attribution. However, there were two sort of randomized trials that were undertaken within the CAPTB project. The conduct study, which I'll hopefully talk about today, which compared two models of care for delivery of household conduct management in Cameroon and Uganda, as well as the input study, which was a step-based trial in Cameroon and Kenya, which has evaluated the ICF components. And hopefully they actually help to provide more concrete evidence in light of this limitation. Thank you very much. I'll stop here for any questions, or should I continue, Finn?
I don't mind. I mean, does anybody have anything specific to that to ask, or we can save for more general discussions after this? Let's save it all for the end. I'm writing mine down as we go.
All right, sure. Yeah, so I'll briefly go through the conduct study, which stands for Community Intervention for TB-active Conduct Tracing and Preventive Therapy Management. Further details of this study are available on the Lancet Global Health, where we published this study. Just a brief background about the conduct study. So it was also funded by UNITAID under CAPTB, focusing on Cameroon and Uganda. It was an RCT which decentralized household conduct management to the household level, and it compared that with facility-based standard of care, which was the control. So in the intervention, they used community health workers to screen children and in some cases initiate TPT in the community. And the primary objective of that study was to estimate the proportion of eligible household contacts starting and completing TPT. And the health economics objective was to estimate the cost, to perform a cost utility analysis of the study using a health system perspective to estimate health impact, costs, as well as cost effectiveness. So in terms of the methods that we use for the health economic modeling, so we use the decision tree approach, where the branches on the tree represented pathways of care for child contacts, and the probability of following the branches of this tree were dependent on child contact attributes such as age, HIV status, antiretroviral therapy status, as well as latent tuberculosis infection status. And costs would accrue according to resource use associated with each pathway. So, for example, TB investigations, ATT or TPT. Then we estimated mortality. We modeled mortality outcomes and expected discounted life years using previous literature assumptions on case fatality rates under treatment or without treatment. And as previously, we used a PSA-based approach in using entry packaging. This is just an overview of the decision tree structure from when household child contacts are screened, investigated for TB, if found with active TB disease, are put on treatment, and then they can live or die. If TB has been excluded, then they are considered for TPT, and they have a chance of developing TB diseases within a year. They can be put on treatment or not, and they can also live or die. This is just pretty similar to what I showed on TB, where we used an ingredient-based approach to estimate costs per child from a healthcare provider perspective. And we based resource use for this analysis from the conduct trial. And as previously, we used unit costs derived from literature to inform our costs for this standard of care. And under the intervention, we used trial financial and expenditure records to actually try and estimate these. And on the right, examples of the activities that we actually estimated unit costs for. So as part of the health economics analysis for the conduct study, we also did a TB patient cost survey to try and see what proportion of households experience catastrophic costs when seeking and receiving tuberculosis preventive therapy for their children. This was based on the WHO instrument, and these are the sort of number of households that we ended up sampling in the study. So just a quick run through the results. So all the results are presented for every 1,000 index tuberculosis patients. So there was an increase in healthcare resource use in terms of the contacts screened, TPT courses are delivered, but there was a reduction in anti-tuberculosis treatment courses, obviously due to the effect of TPT. Then in terms of the health outcomes, the intervention improved prevalent TB case finding, reduced incident tuberculosis, resulting in a reduction in deaths, as well as disability-adjusted life years. And as you can expect, these increases in resource use was also associated with increase in costs, both screening TPT and also as well as prevalent anti-tuberculosis treatment, which eventually increased the overall cost of the intervention, leading to a substantial incremental cost associated with the intervention. In terms of the cost effectiveness, so in the best case, we had ISIS of 620 per disability adjusted life year averted in Cameroon and 970 in Uganda. And on the CIAC there, we're showing the probability of the intervention be cost effective under different assumptions, where in general we would consider the intervention being cost effective under a nominal threshold of about $1,000 US per disability adjusted life year. This is just a quick summary of the TB patient cost survey. The plot is showing how the proportion of households experiencing catastrophic costs defined as household expenditures for TB, in this particular case for tuberculosis preventive therapy, exceeding 20% of the household's annual household income. And as you can see, there is still some household experiencing catastrophic costs. However, the financial hardship is lower if you compare that to children who are on treatment for TB disease, but it's still significant. What we managed to show from the context studies, the incidence of catastrophic costs was consistently lower for the intervention compared to standard of care. Just thought probably some useful result. So in summary, this just summarizes some of the work that we were doing for both household contact management as well as improved pediatric TB services. I've only presented on 2 highlighted in green, but just showing that there is also some work that we've been doing, and there is potential for these interventions to improve health for children, and most of these interventions could be considered cost effective. Just some acknowledgements, and thank you very much for your attention. Over to you, Finn.
Brilliant. Thank you so much, Nyasha. That was fascinating. It was really great to hear such a range of things from you both. I've got a list of questions. Does anybody have any other questions though? Does anyone want to start? All right, let me have a quick look. Maybe Nyasha, if I ask you one, just because it was what you just presented on, and I was just trying to sort of get my head around something. When you, so it was thinking about catastrophic costs in households. So when you prevent catastrophic costs in a household, when you prevent TB in a household that already has experienced TB, we know for drug-resistant TB, for example, like whatever it is, 80% of those households have already experienced catastrophic costs. So when you prevent a TB case in those households, obviously, presumably that really helps to stop that remaining 20%, like nudging them over so that 100% of households experience catastrophic costs. But is that is that what it does? Are there other ways that we can show that it prevents people completely falling, not just experiencing catastrophic costs, but knocking them even further back? I don't know. As a non-health economist, I sort of try and understand.
Yeah. Thanks. I think it's a very good question, and I think well, if you actually prevent TB in a household, then you would be able to sort of reduce the financial hit on that household. But we didn't investigate that in this particular study. What we just did is for children, for households with children initiated on TPT, what did they actually spend in terms of trying to take care of these children as they go through? Obviously, some of them had to go through exclusion of TB disease, and they incurred costs. So, for example, in the facility-based model of care, they actually had to go to the facility to more to actually get some of these services. And although TPTs were free, they may have incurred some costs, and that's what we just demonstrated. But what you raise is beyond, well, at least the scope of the study. But I think if you're able to prevent any TB, then you're definitely going to lower the financial hit on a family. I don't know if Pete, you want to add anything?
Yeah, sorry, also just to say that it wasn't, I mean, I appreciate you've done a ton of work here. I was just trying to think how we kind of think about this more generally. Pete, though.
I didn't really have anything to add. No, I mean, I think everything you said makes sense. I mean, something we haven't figured out is that balance, because obviously, not everybody develops TB. So, not everybody who you didn't give preventive therapy to is necessarily going to get the financial hit from developing TB as a household. But I do think it's interesting.
Yeah, thank you. I just realized we've got like 3 minutes left. I might have to email you some questions, but does anyone else want to ask a question while I try and prioritize quickly? In that case, I wrote down, and I'm trying to remember what the context was, drug resistance from Mark as a question. And I don't remember what the question was. I think I was, it came towards the end. Sorry, I'm trying to remember. So okay, so firstly, I think you didn't have drug-resistant TB within that, but I was wondering if including drug resistance would have meant, oh, sorry, that was it. So it was gene expert machines. So you were doing things like installing gene expert machines, and I wondered if you explicitly considered drug resistance, because obviously that would reduce things like the cost of additional drug susceptibility testing. And I also thought that might make a difference to the cost effectiveness depending on the setting, because of the varying prevalence of drug resistance. And as we go forward, potentially other, resistance to not just RIF, but other things as well, like fluoroquinolones or bedaquiline or whatever in the future. Mark, sorry.
Yeah, no, thank you. So we did not account for, country-specific MDR-TB prevalence. I'm not even sure, where to find the data. I mean, and so again, so I think the only the only way we account for drug-resistant TB, I mean, so we accounted in the cost parameters, treatment costs, we accounted for MDR-TB versus drug-sensitive TB costs, but we did not specifically account for a differentiated, pathway of retesting. Or actually, yeah.
Okay. No worries. Thank you. I was just wondering. With a minute left, I probably shouldn't ask another question. Pete, rates were quite low in these countries. Yeah, I can't remember. Which was the Asian country that you had? Because they were all sub-Saharan Africa.
Cambodia. But of course the kids are the kind of new group as well. So I think rates were kind of below 3% everywhere, and often quite a bit below.
And treatment is increasingly getting cheaper, so it doesn't make as much of a difference, maybe, as it would have done 10 years ago. Okay, thank you. I realize we're at time. I'm really sorry. I did have other thoughts, but they weren't very coherent. But thank you so much both, and thank you all for joining us. We will have another talk in about a month, which I think we sent an email out about, but I can send a link as well if anyone's interested, on TB vaccines in China, and specifically Rebecca, you will know this. I can't remember what it's called, but the Chinese TB vaccine that they presented results on at the Union, which I think a lot of people hadn't seen before.
I think there's the London Journal Club, isn't there, in an hour's time? I mean, I can't make it because I have to go and deal with small people, but
yes, possibly. I can't make that either, I think. But yes, hopefully we'll see you all around and about in a month, if not before. Thank you very much, and see you soon. Thanks.
Thank you.